So it seems there are a bunch of CT scans from the emergency to be reported. And as you guys know, those exams won't report themselves. So let's get to it. And we got here a first exam. It's a 56-year-old female patient. And this is a pulmonary arterial angiography to search for acute thrombosis, so acute pulmonary embolism. I have already downloaded this exam. Let's just load it up on the workstation. I'm just going to anonymize everything so you guys can't tell who this patient is. Of course, that would be bad. And this is the angiographic series. Yep, there are breast implants and an awful quantity of soft tissue emphysema all over the place. I have no idea why this patient is sick. I just got this exam to rule out acute arterial pulmonary thromboembolism. So this is what we are going to do. I'm just going to do an MPR, multiplanar reconstruction, so we can see also images on the coronal plane, because I know you guys enjoy such cute and interesting images. So this is the pulmonary main artery, the truncus, the main artery. This is the right-sided main pulmonary artery, and this is the left pulmonary artery. It has to be white all over the place. It can't be anything else. We are looking for any definitive sign of filling defects. Oh, I know it's heavily this is a very badly done exam. There are too much respiratory breathing movement artifacts, but we can see as much as it's possible and tell if there is pulmonary embolism. So let's see. Yep, no signs of pulmonary embolism on the left. There is a lot of lung and pleural disease, but that's not the focus. Also some adenopathy here, but this is not the focus of this exam. This is a angiographic exam. So let's keep ourselves focused on what is important for the diagnosis we are looking for. So in the coronal plane, I can't really see much. I'm going to get a sagittal view, a sagittal reconstruction, so you guys can enjoy it as well. I am already convinced this is a normal angiographic exam considering acute thromboembolism. There is no sign of such disease, and I'm convinced. Are you guys convinced? I am. Let's go. Let's just get me a normal template for this exam, and this is it. Normal template in place. I'll just sign it off and move to the next patient, because these kind of exams will not report themselves. You know, exams don't report themselves. The platform is kind of slow today, and this is a live recording. This is what it is. I can't really speed it up, and I'm not going to spend my time editing this video just way too much. I don't have free time for that, so I just hit download the next exam. This is a 50-year-old female patient. This is a head CT scan, and it says check the attachment. Okay, I'm going to check the attachment to see why this exam was ordered in the first place. So 52-year-old female, and it says she has some odd sensation after a high blood pressure event 15 years ago. So this is some kind of survey to see if patient had a stroke, a minor stroke, 2 weeks ago. So this is a subacute stroke if it proves to be a stroke in itself. So we have here a brain parenchyma window and a bone window. So we are also going to check a soft tissue window just to be sure and avoid making a terrible mistake. So there is something very odd right here. This is an extra axial lesion, anterior and to the left of the brainstem. This is mesencephalon or midbrain. This is pons, and this is cerebral bulb. Yep, there is. This could be a vascular lesion. This could be a very dilated basilar artery, but this could also be a neoplasm, a tumor. So we're going to describe that. Of course, there is mild white matter disease, probably related to microangiopathy, which is really common on chronic high blood pressure patients. There is some atherosclerotic alterations, features on the internal carotid arteries, and the rest of the brain parenchyma seems okay. So let's look at the bone window. Mastoids are okay, temporal bones are fine, paranasal sinuses, skull base are okay, no osteolytic lesions. Yep, sphenoid sinus are alright. There is a persistent metopic suture, which is a normal variation of a normal feature. This is a disease, but this is really uncommon. Metopic fissure, persistent metopic fissure. This is a fissure, a skull fissure, skull joint that should only be present in uterus and in very young babies. So let's check soft tissue window. Orbits are fine, masticatory spaces are fine, and the uppermost part of the neck is also fine. So we actually have a tumor, or maybe a massive vascular lesion right here. Let me measure that. It's 20 by 10 millimeters. It's called medulla oblongata. Medulla oblongata is this part in in Portuguese, this part of the brainstem is called bulbo cerebral. In Latin, according to the International Anatomical Nomenclature, this is the medulla oblongata. So this tumor is anterior into the left side of such anatomical structure, and it's also extra-axial. It is inside the brain. It is on the it is in the subarachnoid space, the outside of the brain, occupying partially a posterior fossa cistern. So let's describe that. Just going to grab my trustworthy template, of course. Yep. And describe, report, because this exam won't report itself. Feel free to skip ahead. If you look down below on the description of this video, you're going to see chapters. Each chapter points to the start of each exam I read and report on this video. Just remember, this is a live recording. I'm just recording as I work from the office, okay? And if you haven't liked this video, please hit the like button and consider subscribing to the channel. Thank you so much. So I'm just saying there is mild white matter disease on the brain. And there is this lesion right there. Adjacent to the medulla oblongata. Medulla oblongata. It's hyper-attenuating in comparison to the cortex, well defined, and extra-axial. So let's just summarize this report. So the doctor that ordered the exam is happy to read just a tiny bit of the report and go to the next patient. Yep. So there is actually no sign of stroke or stroke-related lesions. So this patient didn't suffer a stroke, or at least didn't suffer a big enough stroke to be readily and easily diagnosed by a CT scan 50 days, 2 weeks after the symptoms arise. So this is it. let's sign this peculiar exam off, clear the cache, and move on to the next patient. So we have now a, let's see, a chest CT scan. It's taking a little bit to load because we are facing some trouble at the platform, but you know, we're doing our best. It is going to load eventually. We are already 15 minutes in. This is going very well, and the exam has loaded. I'm downloading the images. This is a male patient, a 49-year-old male patient, a chest CT scan, and it is supposed to look for tuberculosis of the lungs. He isn't a smoker. This is all we've got of history for this patient. So this is an unenhanced CT scan of the chest to look for signs of acute, active or chronic lesions related to tuberculosis. Tuberculosis, as you guys may know, is a very common and spread out disease in Brazil. I'm from Brazil. I'm recording this in northeastern Brazil, which is arguably the poorest part of Brazil, poorest region of Brazil, and we have way too much tuberculosis here in my region. There are a bunch of kidney stones, but this isn't a abdominal CT scan, but still kidney stones all over the place, bilateral kidney stones. This is a chest CT scan. Just focus on what's important. We are looking for lung disease, and there it is. A bunch of lung scar tissue on both upper lobes of the lungs, especially on the right side. This is extremely common on tuberculosis patient. This patient was lucky because he actually has very little scarring of the lungs. It's usually much more severe than that. Okay. There is no adenopathy, no enlarged lymph nodes. Bones are a bit. There is some degenerative disease of the spine, as you may see right here. So there is some arthrosis, which is quite common because this patient is almost 50 years old. So heart is okay, mediastinal is okay, great vessels are fine right here. Focus. Esophagus is all right. Yeah. Great airways are fine. And lower lobes aren't really diseased, except for the upper segment of the lower lobes that are usually hit by tuberculosis. So tuberculosis usually hits the apex of the lungs and the superior portion of the inferior lobes as well. This is the most common presentation. It is really common for tuberculosis to be asymmetrical in presentation. So you can't really expect the disease to be equal or very similar on both lungs. Yep, can't be a radiologist if you don't drink coffee. Do you disagree? Leave it down in the comments below. Coffee and radiology are a must. So this is great coffee, by the way. Just a bit too strong for my liking, but since we are working emergency cases, yeah, there is. So tuberculosis features, let's focus on this. There is traction bronchiectasis, there are bands, there are calcifications, residual calcifications, there is thickening of the pleural leaflets, so there is pleural thickening, irregular pleural thickening, there are bands, pulmonary bands, and traction bronchiectasis and residual calcifications, both on the apical and posterior portions of the superior lobes and on the superior segments of the inferior lobes, predominantly on the right. So this is what we are going to report. So feel free to skip ahead or stay with me as I report it and mumble to myself. It's okay to go to the next case, I don't mind, but if you want to learn just a little bit more about this disease as I report it, stick around and watch as I type in this report. It's just a couple of minutes. Now, there is no pleural effusion. Pulmonary bands. Oh, crap. Calcifications. Yep, superior lobes. Especially on the right. Oh, and this is it. You also have some degenerative disease on the dorsal spine. Just gonna summarize the report at the end of the report, so the referring doctor is happy when he just skips the entire report and just reads the conclusion, the summary. So everyone is happy. So this is there isn't much of a differential diagnosis considering this is Brazil. This is definitely, as stated by the referring doctor, this is scar tissue that came from a previous post-primary tuberculosis lung infection. So let's sign this one off, clear the cache, and go to the next exam. And the next exam is the one I know you guys like the most. This is an abdominal CT scan of a 67-year-old female patient. This is an unenhanced CT scan of the abdomen, and this elderly patient says she has a left iliac fossa pain, so left inferior quadrant of the abdomen is painful. She also has lower back pain, chronic lower back pain, and also has some urinary symptoms and has spilled blood, so hematuria. Also, she has diverticulitis, has gone through pelvic surgery in the past too. So we are about to see a handful, probably a very complex case of an old patient with multiple complaints on the left side of the abdomen. So I'm just copying and pasting my template for such cases because I just want to make my life as easy as I can. No need to type in what I have already typed thousands of times. So let's go. Let's scroll this exam. This is the liver. This is the spleen. There are no signs of fatty liver disease, and the spleen is quite normal. Adrenal glands are okay. Gallbladder is fine. Remember, we are looking for disease in the left lower quadrant of the abdomen. I'm just checking if there isn't some other disease that we might miss if we go straight to the site of the patient's complaint. So, as this is a full abdominal CT scan, this isn't just some tiny pelvic exam. So kidneys are fine, no hydronephrosis, no stones. There is moderate calcification of the aorta. So this is quite common for the age group of this patient. The gastric chamber, the stomach is fine. Also bowel and colon, right colon, transverse colon, left descendant colon, and sigmoid colon is diseased, is sick. This is the cause of the patient's symptoms. This is the left iliac fossa, since this is the ileus, and this is hypogastrium because it is deep pelvic cavity. So, as you see here, this is a classic presentation of a complicated acute diverticulitis of the sigmoid colon. We have wall thickening, a bunch of diverticula, and fat stranding, fat densification. Also, we have a fluid collection with a bit of gas, a liquid gas level, which means this is probably a intracavitary abscess that comes from perforation of the wall of the sigmoid colon. So if we had a proper contrast enhanced exam, this would be much easier to measure and to tell, because this could be adnexa, this could be remains, this could be remains of the left ovary, enlarged left ovary, or something else. But I'm going to consider this image right here, this entire image right here, a gas fluid collection, thus a intracavitary abscess. So this is just what we expect for a complicated, at least moderate, acute diverticulitis of the sigmoid colon, and it matches precisely the complaints of the patient. So let's just sigmoid colon, diverticular, wall thickening. This is the thickness of the normal wall, and this is thickened walls. So the walls are thick, the fat is stranded, and there is a gas fluid collection right beside the inflamed sigmoid colon. So this is acute diverticulitis. So I'm going to report this case right away. Feel free to stick around or move forward to the next timestamp of this video. So, and yep, no ascites or ascites or free intracavitary fluid, which is okay. No kidney cysts. Gallbladder is fine. And this is it. Just left iliac fossa. So wall thickening of the sigmoid colon. A bunch multiple diverticula. Fat stranding. And the fluid collection. It measures 3.6 centimeters. So we can easily diagnose this is a acute diverticulitis of the sigmoid colon with a intracavitary collection. So, yep, and this is it. Another one bites the dust. Let's sign it off, clear the cache, and get a easy one now, a head CT scan. Let's go for a head CT scan. Taking a little bit to load, but you know, we are 33 minutes in, everything looks fine, and this is loaded. This is a 58-year-old male patient, and he has suffered a hit to the head. This is a trauma patient, trauma to the head. So the exam is about to be, it has finished loading. Let's get side by side a brain parenchyma window and a bone parenchyma, a bone window. So let's check for brain lesions. I know you guys have already seen the big soft tissue, very large soft tissue hematoma. I know, I'm going to point it out. Wait a minute. Let me just focus on the most important part of the exam, which is the brain parenchyma itself. So the brain is fine, the brain is much young than the said age of the patient. Patient it's written right here that the patient is almost 60 years old, but he has a very young and well preserved brain, just a bit of internal carotid artery calcifications, which is quite normal. Can't really say this isn't normal for the age group. And let's look for fractures, facial, zygomatic arcs, fractures, mastoid, temporal bone fractures, no. Temporal mandibular joints are fine. The skull base is okay. Orbits are fine. Orbits and the nose bones are preserved. There isn't anomalous content on the paranasal sinus, and of course you guys have seen that he has a laceration of the soft tissue on the frontal region on the right. This is a subgaleal hematoma, a bit too on the left, and it's all soft tissue. There isn't a bone fracture adjacent to that lesion. See also that this patient doesn't have a persistent metopic suture as we saw on the first patient we reported today. So this is a very mild case of head trauma. There isn't much to be said here but the obvious. So let's get a nearly normal template, because I'm just not going to type in the entire report because I have already typed it a million times. So let's just point out this patient has a subgaleal hematoma on the frontal region, and this is of minor importance. So we are done with the patient. This exam has been signed and has been released. So let's grab ourselves a lumbar spine exam now. This is a 55-year-old female patient. This is a lumbar spine exam, and the patient complains of very severe red coffee. Very severe lower back pain, especially on the right side, for about 5 days. So it's a 5-day pain on the right of the lower back, and this patient is middle-aged, 55 years old. We need 50 seconds to be able to look at the images, maybe less, 30 seconds. Let's grab a template. I have a template right here. It's really uncommon for such patients to not have some kind of disc herniation if they complain of lumbar pain and are over 50 years of age. So this is the axial view, and we're going to hit the MPR button to make a MPR multiplanar reconstruction and look for signs that are compatible or related to the patient's complaint, and I have already seen it. I know you guys are just can't stop staring at this pelvic calcification right here, but just remember we are focus on the exam in place here. The actual exam we are reporting. This is a spinal lumbar spine exam. This isn't a abdominal or pelvic exam, but okay, I'll give it to you guys. This is a uterine mass, probably a leiomyoma, a benign, partially calcified uterine lesion. This is of less importance since this patient is in the emergency looking for a justification, a motive for her symptoms. So we have that motive, that reason here on the spinal, the vertebral exam. So let's keep focus on the actual exam. I just can't really agree with the pain being mostly on the right. I think this patient is suffering from pain, lower back pain, mostly on the left. So I'm just going to zoom in and show you guys why I say that. So this is right and this is left. These are the vertebral bodies and these are the vertebral discs, the ones that herniate. So this is a disc extrusion that goes all the way from side to side, but especially on the left. The same feature is right here on the next segment, and this is it. So we have a L3, L4, and L5 segments diseased with degenerative changes and disc herniation extrusions, which lead to reduced cervical lumbar canal, vertebral canal size. This is reduced in size. This is stenotic. This is also stenotic, and the neural foramina on the right is quite preserved, but on the left there is clearly seen compression of the emerging nerve roots. So this is causing pain. As you can see right here, there is a tiny disc extrusion on L5S1 on the left, partially occupying, partially obstructing the left neural foramen, neural passageway of the nerve roots on the left. So I'm pretty sure the pain the patient is referring is on the left and not on the right, as stated on the clinical history available to me here on the system. So let's just report it. There are 3 disc extrusions on the 3 lowermost segments of the lumbar spine, and also, of course, there are degenerative arthrosis of the facet joints, at least moderate. And let's see the paravertebral muscles. Perivertebral muscles are fine, but the yellow ligaments are thickened, which contribute to the reduction in space for the neural structures to settle and be. So there is some sort, at least a mild stenosis of the vertebral canal in L4, L3, L4, L4 and L5, and there is mild to moderate stenosis of the left neural foramina on L3, L4, L5 and S1 segments. So I'm going to report this, and feel free to skip ahead if you just don't want to watch me mumble as I type in what I have just found. So my template is almost ready. Just going to make a few modifications. Just adding the L5S1 extrusion, foraminal left foraminal extrusion. And there is mild stenosis of the vertebral canal of L3, L4 and L4, L5, and moderate stenosis of the left neural foramina L3, L4, L4, L5, come on, and L5, S1. And this is it. Let's just fix the summary now. It's moderate arthrosis of the facet joints. And you just copy and paste the stenotic considerations to make it easier for the referring doctor to read the report and be happy about it. So, yep, this is done. Once again, we are victorious. So let's see another head CT scan, because I know you guys enjoy neurology. I also enjoy it. We are 48 minutes in, and the system is taking a bit too low today, I know. If you haven't already, please hit the like button, consider subscribing to the channel and sharing this video with people you know enjoys diagnostic radiology. Thank you so much, and let's see if we can report the next exam in the next seconds. Oh, this is taking just way too much. So it's here. This is a post-operatory, post-surgical CT scan of a 70-year-old female patient that has gone through a aneurysm surgery. So we will see a lot of stuff. So the exam has been downloaded already. Yeah, and I'm going to also download the previous exam so we can compare and be happy about it. So this is a massive case. There are ischemic changes on the right anterior cerebral artery territory. So this is ischemic arterial change. There is also a bunch of acute ischemic lesions on the temporal, nucleocapsular region and frontal region of the brain on the left. Also a massive ischemic area on the left posterior cerebral artery on the left, of course. There is post-op features on the left, and gas air inside the brain, inside the skull, which is called pneumoencephalon. Tiny bit of calcification, this is residual. There is some deviation of the middle line, the median line to the right, which denotes, which means there is some kind of brain swelling on the other side, and there are acute hematomas associated with the ischemic changes, ischemic disease. Also, there is some blood on the site of the surgery, and this is the clip. This is the metallic device that closes up the so-called aneurysm. This is probably a anterior communicant artery aneurysm. Is that how it's called? Anterior communicating artery. Anterior communicating artery aneurysm, because it's right there, right on the middle of the base of the skull, just above the Turkish sella. So this is quite a common aneurysm site. So this is a major case. I believe this much bleeding, intraparenchymatous bleeding, isn't supposed to happen. Also, this kind of ischemic changes aren't supposed to happen. This is a very bad prognosis for the patient. Let's see how the brain was a few days ago. So now this is prior to surgery. So prior to surgery, we can't really tell when the aneurysm was, because it is an unenhanced CT scan, but the patient already had those ischemic signs, except for the left middle cerebral artery. Yeah, the left middle cerebral artery wasn't partially closed before surgery. So there are new ischemic changes related to the surgery, to the post-surgery situation. And much more brain swelling. There is effacement of gyri and cisterns. So this is really bad. It's persistent septus pellucidus cavum. This is a anatomical variant of lesser importance. And there is also moderate microangiopathy. There is moderate white matter disease of the brain, mild to moderate, and mild dilatation of the supratentorial ventricular system. So that's reported. This is a very, very severe post-op case. So head CT scans aren't really always that easy to report, as you guys have noticed. So I'm just going to be a bit silent so I can focus on the report. Don't mind me if you can actually skip ahead to the next exam, and I'll see you in a bit. I'm just describing the post-op signs. Now I'm going to describe the acute hematoma on the left frontal lobe. Yep. Now I'm going to report the ischemic changes. Right frontal lobe, left frontal lobe, basal ganglia on the left, occipital left lobe. Oh, there is so much ischemic stroke here. This is major. Yep. Now there is effacement of gyri and cisterns of the left brain hemisphere. Yep, that is reported, and there is deformation or a deformed morphology of the left ventricle. Is a shift of the middle structures to the right, which represents a herniation, subfalcine herniation to the right. Let me measure it. It's about 6 millimeters. So, and I guess this is it. This is what we can tell about this patient. Just check the rest of the template and take out what doesn't make sense. Posterior fossa is normal considering the brain reduction, global reduction in brain volume, but it's not acutely sick. So there is hemorrhagic and right shift. Yep. Just summarize now the report, make it easier for the referring doctor to read it. Oh, I missed the tiny calcifications. And just measure the largest calcification, 4 millimeters, and it's all on the right frontal lobe. So oh, it's done. So subfalcine herniation. One other thing, I have to be sure that there isn't flooding of the ventricles, hemorrhagic flooding of the ventricles, the ventricular cistern, which means a very bad prognosis. There isn't, so this is for the best. And yep. Microangiopathy and calcifications, vascular calcifications. So follow up, comparison. So we are done. Yeah, just let me read it once again to see if I have mistyped anything. So, yep, anterior communicating artery, it's left side hematoma. Yep. Yep, subfalcine herniation. Yep. Yep. So we have finished. It's sign off. So let's go now for our last exam for this video. This is a 48-year-old female patient. This is an unenhanced CT scan of the abdomen. We're gonna have to wait about 20 seconds for it to download. Let's see if we can figure out why this exam was ordered in the first place and hope for something that makes sense. So it's loading up. The exam is here. We have a unenhanced single volume CT scan of the abdomen, and let's see, it's for kidney stones. So we're looking for a motive for a right-sided flank pain related to the kidneys. So most probably kidney stones. So this patient is missing the gallbladder. She has gone under the knife to take the gallbladder off, probably due to gallbladder calculi, stones. The liver is okay, so is the spleen and the pancreas. Pancreas is fine. Pancreas is fine. The adrenal glands, alright. Gastric chamber, the stomach is alright. Colon and bowel seem fine. The appendix is right here. Appendix. The appendix is fine. So we have this is major. She has a hypoplastic hip. The left side of her hip is hypoplastic. It's reduced in size and deformed. There is even a right here. Check this out. See? The hip on the left is really asymmetrical if compared to the right, because this is hypoplasia. This is a congenital, very, very rare congenital disease. So let's get back to the CT scan itself. This isn't the motive of the CT scan. This is just a curious, peculiar fact, and this is a metallic synthesis of some sort related to the hip. So the urinary bladder is okay, the uterus is okay. There is probably a ovarian cyst on the left, but the pain is on the right. Colon, her sigmoid colon is redundant, is elongated, it goes up on the right side of the abdomen and not on the left side. So this is a elongated colon, which is very common on female patients that complain about difficulties to defecate. So I can't really tell. The kidneys are right here. I know you guys were anxious for me to speak of the kidneys, since the motive to do this, the reason to do the CT scan was the suspected kidney stones, but there isn't any stone. There are tiny hypoattenuating lesions on the kidney sinus on the left. These are most probably cysts, about 1.5 centimeters. This is normal. I mean, this is common, not normal, but there isn't hydronephrosis nor stones anywhere that could justify this patient being sick and having pain, having a abdominal ache or lumbar pain. On the right, of course, as you may have guessed, there is advanced degenerative disease on the lumbar spine, because this patient has a major orthopedic deformity on the hip on the other side. So see how much atrophied, so much muscular atrophy here on the left. This is all related to this chronic deformity of the hip. This is most probably the left leg of this patient isn't functional. It's probably paralyzed. This leg is probably paralyzed. She probably uses crutches to walk around. So let's report this exam, because you guys know exams just don't report themselves. I have tried it out. I have left exams all together in the report room for quite some time, and as I got back I realized they weren't reported at all. Cold coffee is almost as good as hot coffee, so it's great coffee nonetheless. So, yep, let's go. Let me get my template for a young female abdominal scan. Unenhanced. No gallbladder. No kidney stones nor hydronephrosis, but there is some tiny, probably cystic lesions on the left kidney sinus. Yep. Appendix is normal. What else? Now the orthopedic signs of disease. This is it. So, just going to summarize to make it easier for the referring doctor. The spinal disease, chronic degenerative disease. And this is it. I'm just going to state on the summary that there are no signs of kidney stones nor hydronephrosis, because it's easier for the doctor just to read this and be done with the report. And we are, there is a previous exam from February, about 4 months ago. Let's just see if someone said anything else, so we can check for ourselves and be sure we didn't miss anything important. Now, as I have stated before, the system is quite slow, so if you haven't done already, hit the like button, consider subscribing to the channel. If you do, hit the notification bell so we don't miss new videos. And I'm trying to upload and publish about 2 or 3 videos a week, all in this format. And feel free to ask questions and on the comments below. So the system has stalled for way too much time. I'm just not going to miss more time. I'm going to, so if you want to watch another video, just hit here and keep watching. And until next time, I'll see you around.